Trauma. Goal to describe trauma-informed care models. There are many faces of trauma.
Operator 911, where's the emergency?
Wind 27 Nightmare.
Okay, what's going on there?
I'd like to order on for delivery.
Ma'am, you reached 911. This is an emergency line.
Large with pepperoni session.
You know you called 911. This is an emergency line.
How long it'll be?
Okay, ma'am, is everything okay over there? Do you have an emergency or not?
Yes.
And you're unable to talk because...
Right.
Is there someone in the room with you? Just say yes or no.
Yes.
Okay, it looks like I have an officer about a mile from your location. Are there any residents in your house?
No.
Can you stay on the phone for me?
No. Thank you.
Most deadliest time is when a person leaves an abusive relationship, and why is that? So, thinking about this, because when they leave, the person who's abusing them no longer has control, so he's aiming to take control back. Understanding trauma. Trauma is a unique individual experience of an event or an enduring condition in which the individual's ability to integrate their emotional experience is overwhelmed, or the individual experience is a threat to life, bodily integrity, or psychic existence. An event or situation creates psychological trauma when it overwhelms the individual's perceived ability to cope and leaves the person fearing death, severe pain, or loss of sanity. What makes extreme stress traumatic? The combination of feeling afraid, terrified, overwhelmed, helpless, or out of control with feeling alone, abandoned, neglected, without restorative or comforting protection. There are 3 types of acute stress exposure to an event: direct, personally affected by the event; observation, witnessed the event; or verbal, heard about the event from a close person. Traumatic incident: stressful, outside normal range of experience, intense psychological/physical suffering with no warning. Responses to trauma: initial crisis reaction, immediate fight, flight, or freeze; physical shock, disorientation, and numbness; enhanced psychological/physical abilities, and fatigue. So symptoms: decrease in energy level, distancing from loved ones, social withdrawal, increased sensitivity to others and violence, feelings of hopelessness, numbing nightmares, negative outlook, changes in belief and values, impaired ego resources, impaired psychological and cognitive schemas, impaired sensory experiences, and disruption in the frame of reference. Shattered assumptions: people develop a sense of what to expect in life. They feel secure knowing what will happen and what won't. After a traumatic event, many people report their basic fundamental beliefs are shattered. They feel loss of sense of control, loss of a sense of invulnerability, which is that it can't happen to me mindset, loss of a sense of world as a safe and secure place, inability to put meaning to the event. 6 kinds of trauma: expected versus unexpected. To everything there is a season. Element of sudden shock, out of the blue, past history revisited. Element of personal history, backwards glance. Element of unfairness, foul play. Element of control, powerlessness, the fickle finger of fate. Try saying that 5 times fast. The fickle finger of fate. Anyway, element of blame, it's just pointing the finger. Places to find trauma: everywhere. Why me? What happened? How long will it affect me? Why is it important? So there's a lot here for this one. I can't read all that small writing. The brain is composed of multiple parts, which means in the event of trauma, more than one part of the brain is affected. When the individual is attacked and a threat to one's homeostasis is made, the first part of the brain to become aware of the chaos is the amygdala. The amygdala then processes the information received and will react at the level of emergency in which it is. At this point of time, the individual is consciously unaware of the danger, but their physical body, the neurobiology, evolutionary savvy brain has already begun to work out a safety plan. After receiving the threat, the amygdala sends a signal to the hypothalamus, where it again states that there is danger and action is needed. The hypothalamus then signals the pituitary, activating the HPA axis, responsible for the release of hormones. The hormones release is directly linked with the victim's reaction to the trauma. Maybe here. 4 of the most commonly released hormones after a sexual assault are known as catecholamines, cortisol, opioids, and oxytocin. The levels of each hormone present in someone after an assault depends solely on the individual's psychological response. It's important to note that an individual's response to the trauma is driven not by the consciousness thoughts, but their body's physical reaction. The first hormone released are the catecholamines, also known as adrenaline. During an assault, this hormone is rushing through one's body. This hormone is responsible for the flight, fight, or freeze response. If the situation calls for one to fight back, this will give the individual the drive and means to do so. However, it may be more beneficial to flee the situation and try to run from the impending danger. Both of these responses are aided by the high levels of catecholamines. Though helpful in terms of adrenaline, these hormones impair circuits located in the prefrontal cortex, which controls rational thought. The part of the brain that allows people to think logically about their actions in a cause and effect manner can no longer work efficiently when catecholamine levels are high, which means during the assault, the process of if I do this, then maybe I could do this does not work. If one's body cannot even think these of the options, then acting on them is impossible. The second hormone present is opioid, which releases a very high level during sexual assault. The hormone blocks out the physical and emotional pain. Anyone who understands the extent of opioids has on the body knows that it truly blocks out all pain. This means from the time of the assault to a duration after the assault, the victim's emotions may seem more monotone or flat with very little emotion. Opioid levels released at the time of an assault can remain elevated for 96 hours after the event. If a traumatic event is seen as horrible, then why is the victim acting as though everything is okay? The neurobiology of trauma has given us insight into the cause of this reaction. Hormones. Oxytocin, pain buffer, tries to increase positive feelings. Opioids blocks physical and emotional pain, often present during sexual assault. Adrenaline impairs circuits located in prefrontal cortex to control rational thought. And corticosteroids, stress hormone, regulates energy. Factors that lead to trauma-informed care: veteran homelessness, trauma exposure, and PTSD. The 3 R's. Realize the prevalence of trauma. Recognize how trauma affects all individuals involved in the program, organization, and workforce. Respond by putting this knowledge into practice. Types of traumatic events experienced by homeless veterans. Crime victimization, interpersonal violence, accidents, life-threatening illness, natural or man-made disasters, combat, captivity, military, sexual assaults. Considerations for care: number of traumas experienced by the individual, multiple interpersonal traumas are most common among homeless veterans. There is an 85% increased risk of a previously homeless veteran becoming homeless again. 71.1% of homeless veterans reporting experiencing adult physical assault. 20% of homeless veterans seen in VA centers carried a PTSD diagnosis in 2012. And 75.3% of women veterans have combat-related PTSD. Common reactions to PTSD: feelings of shame and guilt, aggressive behavior, suicidal thoughts, and detachment. Trauma. The impact of trauma is very complex and leads to common behaviors such as avoidance, substance abuse, isolation, feeling different due to experienced trauma, poverty, medical problems, mental health problems, the lack of understanding of how the trauma has impacted their lives, unawareness that they even experienced a traumatic event. Supportive recovery. Assessments and access. Assesses needs and provides access to services. Evidence-based practice. Use of current best evidence in making decisions about patients' care. Create a safe environment. Very important for the client to feel safe when meeting with an individual. Recovery is about building on strengths, resilience, and hope. Trauma-informed care concepts and trauma-focused specific care. Concepts: have a basic understanding of the trauma experience, create a feeling of safety both environmentally and emotionally, use of strength-based approach, focus in specific care, cognitive processing therapy, prolonged exposure therapy, EMDR, acceptance and commitment therapy, and dialectical behavior therapy. So you kind of see here PTSD and then trauma-informed care, and then like where some of the stuff on TBI and where some of the stuff overlaps. Strength-based approaches. Rebuild control, offer choices, identify strengths, promote and reward social engagement, support decision-making. Creating environmental safety. Post clients' rights, ensure privacy, manage noise level, be sure there is an easy exit that the client is aware of, have choices for seating, consider lighting and signage, decorate the space to feel welcoming, and make it accessible. The trauma lens. Consider how you might answer these statements versus how your client may answer these questions. Your view may be more positive, whereas their view may be more negative and dangerous. Okay, so I am a blank person. The world is a blank place. People are blank. Tomorrow will be blank. So I would answer these as I am a good person. The world is a safe-ish place. People are okay. Tomorrow will be better, whereas someone with trauma might answer it as they're a bad person. The world is a bad place. People are bad. Tomorrow will be bad. You know what I mean? Anyway, next slide. Veteran barriers to trauma-informed care. Little or no support systems, emotional pain, self-blame or shame, belief that talking about it will make it worse, belief that providers cannot be trusted, substance abuse and dependency, limited positive coping strategies, criminal charges, underemployment or unemployed. Tips. Give the veteran control of the process. Be aware of intense feelings of guilt and shame. Give a self-administered checklist to the client prior to getting started. Avoid judgmental language. Provide education and support. Give the veteran the choice to answer. Be sensitive and understand and be aware of triggers. Trauma-informed care competencies. Screening, awareness, understanding, engagement, and commitment. Visit ptsd.va.gov for more information. TIC, trauma-informed care. Practice psychoeducation and parenting, relaxation, affect modulation, cognitive coping, trauma narrative, intuition, cognitive processing, and in vivo exposure. Trauma is often complex because of the sheer number of events folks go through. So, evidence-based practice models of intervention include grounding, prolonged exposure, seeking safety, trauma narrative, stress inoculation, training, trauma-informed care, trauma recovery, empowerment model, and sanctuary model. So that's it for this video. Thank you for listening.